of a central centrifugal starting alopecia, which we looked at burning pain, but the definition itself is, I won't discuss today those cases where there is a clear-cut scalp disease. I have to mention that in the literature there's a lot of data that is associating it with hair loss with different types. But clearly this is something that when we see those patients, it affects the quality of their life, and a lot of times these patients don't sleep. So what about the prevalence? And here I have to disappoint you that there's really limited data in the literature. It seems to be more common in women in older age, and a large study in hair clinics published in 2002 mentioned 20% of women. I think Dr. Traub is sitting here in the audience, mentioning that 20% of women with hair loss and 9% of men complain of scalp pain. My colleague Laurent Misri had another large study in France. He mentioned sensitive scalp is, again, in that not clear if it is clear burning scalp syndrome, but among 1,100 individuals in the French population, 44% declared suffering from some type of sensitive scalp, more in women. 30% complained of prickling, 25% of itching, and 2% of burning or pain. So if we look at the 2%, this is quite significant. When they analyzed the data, the triggering factors were considered to be pollution, heat, emotions, and shampoos. No other area of skin sensitivity was specifically associated with scalp sensitivity. And again here, the data is a bit kind of limited, but I kind of gathered the patients I see, and I see all these unusual dysesthesia. Most of them come because dermatologists think that if I'm an itch expert, I know a lot about pain, but most of the patients have these spontaneous pain, and it's evoked by various stimuli, including combing and washing the hair, as well as bundling the hair for 1 hour. Now going into kind of understanding the innervation of the scalp. So the scalp is actually extremely highly innervated, and there's 6 sensory nerve branches, both trigeminal as well as cervical, and there's actually also overlap in what we call watershed areas. So you would expect that the scalp is very sensitive to any neurostimuli, and not just innervation is significant, but also the blood circulation. It's a very bloody kind of area. There's both significant vasculature from internal carotid, external carotid, and occipital arteries. But one of the issues that is interesting in the scalp is that the hair follicle is really a neural structure, because it contains almost all the receptors for pain and itch, and particularly when we look at receptors for nerve growth factor, that we know is involved in sensitization of pain, possibly also for itch. It involves also CGRP, substance P, neurokinin 1, its receptor, endorphins. It has also cannabinoid receptor, abundant cannabinoid receptors in the hair follicle, both in the outer loop as well as in the inner loop. And clearly, if you have such a neural structure, it has some role in this pain and itch. And this is a very nice figure of Marna Eriksson from University of Minnesota, showing that PGP 9.5 is a marker that we use for staining nerve fibers, and her group with Marna Eriksson has shown very nice studies here of innervation of a hair follicle. So one of the issues that I was interested, if the scalp is so innervated, you would expect that there'll be a lot of studies looking at the sensation of the scalp. And in fact, there are very few of them. And my former fellow, Gada Ben Seif, did a very nice study with us looking at sensory testing of the scalp and looking at warmth temperature thresholds, heat pain thresholds, and we looked also at itch response. I won't discuss this part because this is more for the itch lecture I'll give. But what was interesting, and to our surprise, is although the scalp is highly innervated, and this is healthy subject, when you look at the thresholds, usually for forearm, the threshold for detection of a sensation, this is with a Pathophysiology mode, is around 34 degrees, 0.8, where it starts at 32 degrees. This is around the temperature of the skin. But when we looked at the crown and occiput, you could see that the subjects cannot trace this warm stimuli, and it's actually almost like a neuropathy, meaning that they don't really feel a heat, pain, or warm. This is a warm sensation threshold, I'm sorry. This is really abnormal in comparison to any disease. Even if you look at diabetics, when you do these measurements, these are quantitative sensory tested devices that are well known to be done as a tool for assessment of senior fibers and A delta fibers. These are the fibers that transmit pain and itch. And when you look at heat pain thresholds, similarly, you can see that they tilt 49 degrees, 0.9. It's actually the maximum almost of sensitivity because the stochastic mode goes up to 50 degrees. The subject did not feel heat pain. And as you can see, that there's a big difference. So in kind of summary, the scalp is actually has lack of sensitivity to painful stimuli as well as warm sensation, meaning that there's something abnormal going on here. Although this is not burning scalp syndrome, one of the interesting things is central centrifugal scarring alopecia is a form of scarring alopecia very common in African Americans. And while I was at my former work in Wake Forest, we did a study on looking at patients there have a lot of times burning sensation and itch. And when we looked at their heat pain threshold, again, there weren't significant differences with the healthy. And again, there was a elevated warm threshold in comparison to forearm as well. This is the healthy, but in comparison to the scarring alopecia, there is no difference, suggesting that again, there's an abnormal sensation, and I would expect that since these patients are very sensitive to a painful stimuli, they would be more susceptible to these heat pain or warmth stimuli, and they don't have that difference. So this is a bit striking in the way how our scalp is acting. But the question is, could burning scalp be a form of neuropathy? So a recent study published in the Journal of Clinical Pain by an Israeli group has looked at 16 patients with burning scalp. These are patients who were classically burning scalp with no skin disease known, and they were tested this time not for warm sensation or senior fibers, but actually for more touch and pressure pain thresholds. But these are the different modalities in terms, and they were testing painful and pain-free sites versus healthy. They also analyzed the hair. And what they found was, first of all, 12 patients reporting having allodynia. What is allodynia? Is that when you apply a non-noxious stimuli, it's translated to pain. And when they were applying relatively light pressure on the finger or just applying a tiny pad, they were very sensitive. 5 patients noted that hot water on the scalp or hot blow dry is especially painful. And 6 patients also reported that there are times that the scalp here is so painful that they cannot lay their head on a pillow. They rated the VASC with a visual analog scale as a VAS of 6. So it's quite significant. And when they analyzed the thresholds for a light touch and pressure pain, there were increased thresholds. So their results were a bit different from ours. They were very sensitive to allodynia by touch and pressure. And there was a significant negative correlation between chronic pain intensity and these thresholds. So when you have lower thresholds, they're more sensitive, and there was a correlation with pain intensity, which was higher. So the results, these researchers have shown that these patients who have burning scalp syndrome have this sensitization of the nerve fibers, and they suggested that this is a peripheral and central neurosensitization. So another question is, what about skin biopsies of burning scalp syndrome? And here, I have to admit that there are really very minimal reports, but I found one actually from a Korean colleague who was publishing it in an abstract form in Australia in the World Conference of Hair in 2010, where he looked at messenger RNA expression of substance P, nerve growth factor, and neurokinin 1. Neurokinin 1 is the receptor for substance P. And all of them, these are just K series, were higher levels showing higher levels of these messenger RNA, as well as the cytokines TNF alpha and interleukin 6 in patients with burning scalp. So clearly more work needs to be done in this field because these were only case series, but it does suggest kind of that the burning scalp is actually a sensitization phenomena, and I have to explain that this is an area that really is on the core of understanding how we treat these patients. So we know that in chronic pain, in a lot of types of chronic pain, if it is chronic pain associated with neuropathy, if it is chronic pain with irritable bowel syndrome, if it is chronic pain with fibromyalgia, there is a altered sensory stimuli, and most probably those with burning scalp syndrome have the same type of hypersensitization. And that's why now you'll understand a lot of the treatment that we use are dealing with drugs that are known to reduce the sensitization phenomena, in particularly SSRIs and anticonvulsants. But I'd like in the periphery and in the scalp to give a lot of emphasis of ion channels from the TRIP channels. I think these are crucial to better understand that sensitization phenomena. And again, a lot of work has been done from Ralph Paus' group on TRIP-A1 channels. And also we now know that TRIP-A1 have a role in the sensitization phenomena and sensation of burning sensation as well as itch and pain. And clearly they work also with a lot of the mediators involved, and when we have inflammation, and it could be also that when we start picking on the skin that there is oversensitization, it kind of triggers this cascade. So another interesting molecule that I mentioned is nerve growth factor. Nerve growth factor has been shown to be a neuropeptide that induces that sensitization. It is associated with the TRPV1 activation, and we know that in pain at least, we know that this is a target for treatment, and recent studies suggest that also blocking its receptor with TRPV1 could actually reduce itch, but most probably also would reduce the burning sensation. I'd like to mention also that a lot of the patients with burning scalp syndrome have something that a lot of us see and hear disorders is stress, and clearly I've worked with one of the dermatologists here in Korea. I don't think she's in this meeting, Hazel Kim, on assessing the stress response in the autonomic nervous system, mainly in itch, but clearly the autonomic nervous system aggravates and intensifies both the pain and itching in the skull. So now going into the practical measures of how can you manage burning scalp. So I would mention a bit topicals, focusing on ion channels, and then discuss a bit oral anticonvulsant and oral antidepressant. So one of the treatments that I use I would say that has some success is the combination of capsaicin with an anesthetic. This treatment does reduce that ion channel between V1, and I would say has its role, but do keep in mind that you have to let the subjects know that initially they won't like you in the first month because initially it causes more burning. So it's not an easy treatment to do, but the fact that you give AMLA prior reduces that burning sensation. And I know it sounds a bit difficult for us to understand, but the more you apply capsaicin initially in the first 2 weeks, meaning 4 times or even 5 times a day, you'll reduce that burning sensation faster. Now, another treatment that I use for this type of burning skull syndrome, and this has been used by my colleagues at Mayo Clinic, is targeting several ion channels. Ketamine is a drug that is an anesthetic. It works on the brain, but I'm not going to give it that will have a systemic effect. It is an ion channel, and combining it with amitriptyline and lidocaine again targets locally the nerves in this area. Another option that we have explored, and I know that Dr. Hordinsky here group also was using, is topical gabapentin. We use 6%, but you can go up to 12%. And this again, most probably a bit numbs that hypersensitization phenomena. I have to admit that at this stage, I don't have enough data to support the use of it, but clearly I'd be exploring that more and more, and be happy and delighted to hear from Maria if there is any yield in this type of population. But this type of combination, using in a good vehicle of lidoderm, really enables the patient to numb that sensation of burning. Now, this is my therapeutic ladder, so I do use topical capsaicin and AMLA. I go up with topical amitriptyline, ketamine, and lidocaine, and then going up into oral medications. And I won't mention Botox, although it has some role in injections that we're testing now. But I would say that the high dose of anti-epileptics and antidepressants with combination has been the most successful treatment for my patients. And I usually use mirtazapine because this is a SNRI that has shown to, in my experience, the better efficacy in itch. But in patients who have burning skull, duloxetine or Cymbalta works well too. This drug does not work at all on itch, unfortunately. I use the combination of gabapentin or pregabalin in very high doses, so you have to be a bit careful in immediately using this. So I use it gradually, increasing it, because if you give a very high dose initially, the patient would not tolerate it and would have side effects. But one of the issues that I see a lot in dermatologists is we're kind of afraid of using these drugs, so we use very low dose. So a low dose most probably would not work on these patients. So clearly, to kind of summarize what I mentioned to you on burning scalp syndrome is a better understanding of pathomechanisms and the neural processing, targeting these specific mediators and receptors and those neuronal pathways would enable us to provide better treatment. So clearly, this is an area that we need to know more about the prevalence, and we need to know more about mechanisms, how to the pathophysiology to better target specific treatments. So I think I'll thank you, and if there are any questions, I'd be happy to address them.
Now this presentation is open for question and discussion. Professor Lee. I'm Dr. Lee from Samsung Medical Center, Korea. Actually, I have experienced several people having burning scalp. I recommended a biopsy, but biopsy showed nothing. So in that case, in addition to skin biopsy, can you recommend any other tests or?
When you say skin biopsy, did you stain it for nerves or?
No,
So I'm not expecting, what I showed on the biopsy was just looking at neuropeptides and mRNA. It's an interesting, I didn't see any study, we look a lot in my lab on innervation patterns. I didn't do burning scalp, so I can't tell you, but I have to tell you that even if I would do that, I'm not expecting that I would see something dramatic, but clearly with double immunohistochemistry, so I don't think it's for the clinical application, it's more mechanistically, I'd be more interested to know and explore the neuropeptides involved in this sensitization phenomena. In terms of workup, yes, if you don't see, and that's where I'm trying to say is if you don't see any inflammatory disease, most probably the patient who has burning scalp syndrome is suffering from burning scalp syndrome. So I wouldn't start looking into very extensively more than what you're seeing without a biopsy. So your clinical judgment is very important. I did mention here that there are patients who have postherpetic neuralgia, but you may not see anything and they had herpes zoster there, and that could cause the burning scalp. But I didn't mention that because per definition, it's not really a burning scalp, so there is a clear-cut history of a rash before. But one of the interesting things that I would mention is I have it more on the itch side, so I didn't look at it in the scalp. Diabetics have more itch in the scalp. This I'll present in the plenary lecture, I think in 2 days, is that we did a very large geriatric study and found out that around almost 20% of the adult population of geriatrics have scalp itch. And when we analyze what association, it goes with diabetes. And I have a feeling that diabetic neuropathy has a role. I don't know about burning scalp. It won't surprise me that some of the patients with diabetes may have diabetic neuropathy as their burning scalp. So if you would ask me, I would look at comorbidities like diabetes.
Thank you for a wonderful talk. You mentioned earlier that the hair and the scalp express cannabinoid receptor 1 and also TRPV1. Would you expect that cannabinoids would affect burning scalp?
It's an excellent question. It's one of those $1 million questions. This is where I think, this is my hypothesis, is that cannabinoids here are anti-nociceptive. So they may serve something good for us. That I don't have yet approved, but if they're there, they're for a reason. So yes, cannabinoids of that sort have a role also in barrier function, most probably. But I have a feeling that they do something for the good of it. Not that I'm trying to promote use of cannabinoids for burning scalp syndrome, but from my perspective, something is, why are they so abundant there? There's some kind of role that they have. I wish I would know, I don't.
Thank you for your wonderful talk. My name is Ralph True from Zurich. I was wondering, do you also check for psychiatric or psychosomatic disorders? Because there is a subset of these patients with a burning scalp as a symptom of an anxiety disorder or depressive disorder or a somatoform pain disorder.
Excellent question. Yes, I do. Clearly, I agree with you. My focus was trying to identify those with the sensory aspect, but clearly, as I mentioned, stress and depression, obsessive compulsive disorder can also be associated with burning scalp syndrome. So you're perfectly correct. My approach today was to try to tackle those who are a bit beyond that, that we really think, and you agree with me, there are those patients who have just solely sensory aspect rather than the whole gamut that, major depression, and then we tease them away. But there is an overlap, clearly. So what's the egg in the hen is another question, but I try to focus that we need to target also the neural aspect. Yes.
Any other questions? Have you noticed the burning scalp syndrome associated with some burning sensation of other parts of the skin?
Excellent question. I would say yes, and I didn't mention that a bit, but we have collected data that this is another area that is still in involvement, is if you look at burning scalp syndrome, if you look at fibromyalgia and irritable bowel syndrome and vulvar burning sensation in women, there's a lot of denominators that are common. I don't have enough information at this. We're actually looking at it with several groups. And that's why I wanted to be careful, but clearly there is in that category people who have that sensation. I was more focused on those who just come with that burning scalp as the initial and the only complaint. But I perfectly agree with you that if you look carefully on your patients with other psychosomatic, I'm not saying that fibromyalgia is a psycho, I think all of these are narrow elements where there is a component of hypersensitization phenomena. If it is also depression associated or other psychosomatic aspect, clearly there is an overlap.
No questions? Okay, thank you, Professor Gill.